Thank you. My name is Martin Nylund. I'm an epidemiologist and a full-time clinical researcher at the Department of Orthopedics at Lund University. Okay, so I'm going to focus on the potential of register data to study the burden of musculoskeletal disease on society. So I'll give examples of different studies possible, and this is just sort of very, very few examples. There are endless possibilities to utilize register data in research to gain knowledge. So first off, I'll give some examples of sort of basic epidemiology to give estimates of disease occurrence in the form of incidence and prevalence of disease. I'll also look at comorbidity patterns of disease. I will give examples of treatment evaluation, which also gives the possibility to do calculations on health economy. And also finally, a very neat example of sort of risk factors for disease. We have a lot of Swedish nice registers, and I will just mention a few of them. This is the population register, which keeps track of residential address and marital status and so forth. We have regional inpatient and outpatient healthcare registers containing, for example, diagnostic codes, so forth. We have a register to keep track of prescribed drugs. The National Board of Health and Welfare have registers, for example, of cause of death and also in hospital care on a national level. We have the Social Insurance Agency that keep track of sick leave and disability pension. And we have Statistics Sweden that have information of education, occupation and income and so forth of Swedish residents. And importantly, all these registry resources can be linked together by the unique personal ID number carried by all Swedish residents. So we are now in Sweden, in the southern part here. I apologize for the weather. And first I'm going to mention some results from looking at regional healthcare data from this region. We have a register that contains all visits of all the total population in this region with certain date of visits, the level of healthcare, and who the healthcare provider was, and also the diagnostic codes according to the ICD-10 system. And just by utilizing one register, there's no cross-linking here, we can gain actually very important information. This is an example of the annual incidence per 100,000 of radius fracture of the wrist. So there's a number of new cases during a 1-year time frame. And what you see here is we have the children here at peaks, especially the blue one is boys and the red line are women, here girls. And clearly you see boys, they do skateboarding and climb trees, so forth. I have almost 1 in 100 boys per year fracture their wrist. Then it rapidly drops down, and then we see here it starts to increase in the women, so they climb trees and do snowboarding. No, you see this is actually about the age of menopause in women, and this is a reflection of osteoporosis, big burden on society. So this is just one example how you very easily can gain information of disease occurrence using high quality register data. I'll give you another example which sort of quite opposite pattern here. It's peaks in the working ages. This is carpal tunnel syndrome. It's a compression of the median nerve, also more frequently found in women. And we can also gain estimates of prevalence by actually cross-linking with population register, because we can scan the registers for certain diagnostic codes, and then we can cross-link with the population register to exclude subjects who have died or relocated to gain good estimates of point prevalence of the condition. This is rheumatoid arthritis, one of the key rheumatologic conditions. And this is age on this axis here, and this is the prevalence. And you can see it's sort of rapidly prevalence increases by age, and about twice as common in women. But it drops a little bit in the most elderly here, probably a reflection of the increased mortality with rheumatoid arthritis. We can also study what else do these patients come for healthy, what other diagnoses do they get? So this is an example of ankylosing spondylitis patients. This is a rheumatic inflammatory back disorder. And we can calculate sort of the rate of other diagnostic codes, for example, uveitis or inflammatory bowel disease, and we put that in relation to the rate of disease occurrence in the background population who have sought healthcare. So we can calculate actually a rate ratio here. So 1 means there is sort of no increased rate. So for all these conditions, so you see there are increased risk of these conditions in patients with ankylosing spondylitis. And this is also show some, they have increased rates of cardiovascular disease and risk factors as well. And this is important because now we can gain important information on the total burden of certain chronic diseases. Very powerful method to look at this actually, using data that's already available in there. And it's done on a population level. There's no sort of direct selection bias or so on. It's entire population. Now I'm going to give another example of cross-linking data. This is a work done with a treatment register for rheumatoid arthritis in southern Sweden called South Arthritis Treatment Group. That register contains all new treatments with modern biological treatment, the TNF blockers. And we have cross-linked that with data from the National Insurance Agency to see how sick leave is affected. So this is entirely population-based data. It's no sort of randomized controlled trial or selection, but this is what happens when you introduce this drug in society, at least in the southern part of Sweden. So on the y-axis, this is a percent, and on the x-axis you have days. These are 360 days before start of treatment, and day 0, this is start of treatment, and this is 1 year after treatment. So in these black dots here represent the proportion of RA patients currently on sick leave. So 1 year before treatment start, about 20% are on sick leave, and it sort of climbs up here, about 35%. And then after treatment start, it increases to about a level of 30% here. So clearly you see there is something occurring here. And at the bottom here, we have a matched age and sex and also geographically matched reference subjects to represent sort of the background population of this age and sex distribution. So about 5% are on sick leave in the background population. And the difference between is actually a measure of the burden on society due to this RA population here. So you can gain a lot of information from this type of cross-linking of data. Right, we can not only evaluate effects of pharmaceutical treatment, we can also put this methodology to any kind of treatment, for example, surgery or rehabilitation and so forth. This is an example of total joint replacement in osteoarthritis patients. So this is the same, this is a proportion here on the y-axis, and this is the days, 360 days before surgery, this is the day of surgery, this is 1 year after surgery. And the red ones are hip replacement patients, and these are knee OA patients who get their knee OA replacement. So you see here quite a high baseline level of sick leave, slowly climbing, and knee OA patients a little bit worse off than the hip OA patients. These are all in working ages, I forgot to mention that. These are between 18 and 64. So, and as expected, around the time of surgery, it peaks and then it drops back again, sort of back to around the level they were 1 year before. Interestingly, so a large proportion are still on sick leave, so we're going to go forward and see why so. It's possibly there are a lot of comorbidity associated with osteoarthritis. And once again, this is population-based data. This is what happens when in society when you do a treatment. Very powerful method. So finally, I'd like to mention a study from a PhD student of mine. He has retrieved the PE, physical education grade, in a large number of students in Sweden for a long time ago from handwritten records, where they also had the personal ID number recorded. And then we have linked that data to our healthcare registers to see what diseases they have 30 years later. And what we found was that women with a low-grade NP were associated with a high frequency of soft tissue, in particular soft tissue pain syndromes. And we are going forward to see more what this sort of represents. We are planning to utilize the Swedish conscription register, which contains data on basically all Swedish men who has been enlisted for military service, containing very nice information on cardiovascular fitness, muscular strength, intelligence, and so on. So this is just a few examples of the power of registers to do very interesting research, and a very powerful tool to study the course of disease and the effects of treatments and so forth on a societal level. Because we are facing an increased burden of musculoskeletal disease in society, not only arthritis, because we get older and we get heavier and so on. Thank you.